First, we will give a brief introduction. What is antiphospholipid syndrome? We will talk about clinical manifestations and antibodies. Next, we will move on to discuss the classification criteria, with a particular focus on the new 2023 criteria. And then we will talk about the 2019 EULAR treatment recommendations. The second part of the session will be dedicated to topics covering 4 subjects that I found interesting to present here today. First of all, antiphospholipid syndrome is a systemic heterogeneous autoimmune disease, as you may have already heard. In the other sessions we've been reviewing throughout the day, and it is characterized by the presence of thrombosis, obstetric complications, and other non-thrombotic manifestations. All of this occurs in the persistent presence of antiphospholipid antibodies. APS can be classified as primary or secondary when it is associated with other systemic autoimmune diseases, especially lupus. As for its clinical manifestations, they are highly variable, heterogeneous, and are not limited solely to the presence of thrombosis. It is important to remember that we should suspect this disease in patients who present with unusual thrombosis. Regarding other non-thrombotic manifestations, we should highlight thrombocytopenia and valvulopathy, which, as we will see, are manifestations that have gained importance in recent years, and as we will see, are included in the new classification criteria. And then other manifestations that we will be reviewing throughout the talk. Antiphospholipid antibodies are autoantibodies that are directed against proteins and phospholipids, being the main antigen recognized by these antibodies. Beta-2 glycoprotein I. This is a plasma protein that has 5 domains, with domain 1 conferring its pathogenic role and domain 5 allowing it to bind to membrane phospholipids. It appears that there are 2 fundamental processes involved in the formation of antiphospholipid antibodies. One is infections, and the other is protein folding. Both mechanisms, abnormal folding and infections, are best described in relation to anti-beta-2 glycoprotein I antibodies. However, we know that not all patients who carry antiphospholipid antibodies go on to develop clinical manifestations of the disease. According to the double-hit theory or model, it has been described that a second factor associated with the antibodies is necessary, such as predisposing genetic factors or other prothrombotic factors for the clinical manifestations of the disease to develop. As for the lupus anticoagulant, which I myself used to confuse as well, many times we mistake it for an antibody, but in reality it is a test. And it was first described in the 1950s in patients with lupus, which is where its name comes from. It is also paradoxically called an anticoagulant because in in vitro tests it has been observed to prolong clotting times. These clotting times are phospholipid dependent. We will explain this further in the next slide. And then we have 2 other antibodies, which are the anti-beta-2 glycoprotein I and the anti-cardiolipin antibodies. These are measured or tested using ELISA tests. Both the lupus anticoagulant test and these 2 antibodies are included in the classification criteria. To explain and better understand what the lupus anticoagulant test is in order to ILA. The first thing we need to know is that what it measures is the presence of antiphospholipid antibodies in the patient's plasma. This test consists of 3 phases. The first is the screening phase, in which Russell's viper venom is added to the patient's plasma. This venom activates the phospholipid-dependent coagulation cascade. In the presence of these antibodies, what would occur is a prolongation of coagulation times, and proper coagulation would not take place. In the second phase, the mixing phase, what is done is the addition of normal plasma C, which contains clotting factors. However, when this normal plasma is added, we would not be able to reverse the coagulation abnormality. And for example, to illustrate it better, in patients who have a deficiency of clotting factors, adding normal plasma would indeed correct this coagulation defect. And finally, we have the confirmation test, which involves adding an excess of phospholipids, and in this way, with the phospholipids remaining free and not bound to antiphospholipid antibodies, the coagulation defect would indeed be corrected and would proceed normally. Now moving on to talk about the classification criteria, as was already mentioned this morning, they are not diagnostic criteria. In fact, the classification criteria are used to identify patients who very likely have the disease in order to include them in studies and clinical trials. That said, the first classification criteria for APS were published in 1999. And later they were revised in 2005. They were published in 2006 and are known as the Sydney criteria. And these are the criteria that until now all of us were familiar with. However, in 2023, ACR and EULAR published new criteria that, as we will see, include quite a few updates compared to the previous ones. Briefly, the Sapporo criteria were originally created with the idea of trying to define the clinical features of antiphospholipid syndrome and to highlight the pathogenic role of the antibodies. And these criteria, which are shown here, and I won't go into detail on them, were later revised. Among the new features included in these updated criteria is the establishment of a 5-year limit between the clinical event and the positive laboratory test. They also emphasize the importance of the persistence of antibody positivity, setting a threshold of 12 weeks. And in addition, for the first time, they include anti-beta-2 glycoprotein antibodies as a classification criterion. They also make a distinction regarding the threshold for positivity, which is set at 40 units or the 99th percentile. And the ACR-EULAR criteria, which were developed with the aim of improving the diagnostic accuracy and reliability of the classification criteria. These criteria are based on a very rigorous methodology, aiming to use the strongest possible evidence, and the system they use is a weighted and additive system, different from previous ones, in which two things are important when quantifying the clinical criteria. First, it will only be counted as a clinical manifestation criterion when there is no alternative cause that could explain it. And finally, just like in the lupus criteria that were reviewed in the previous talk, we should only count the criterion with the highest score within each domain. Additionally, due to the design of the system, it seems that one advantage could be its flexibility and the possibility of modification if needed in the future. Other new features or differences include entry criteria for the first time, also following criteria similar to those for lupus, and in this case, they reduce the time limit between a clinical event and a positive laboratory test to 3 years. These criteria were validated in 2 international cohorts of approximately 900 patients, but nevertheless, there were some populations, such as Black individuals, that were not truly well represented, and therefore, the applicability of these criteria in these populations could be limited. As you can see, it has a very high specificity. The previous Sydney criteria had a specificity of 86%, so this aspect has improved significantly, but at the cost of reduced sensitivity, resulting in a high false negative rate of 16%. Therefore, up to 16% of patients who actually have the disease will not be classified as such. Regarding differences in the clinical criteria, well, for the first time, a risk stratification is included in the macrovascular thrombotic domain specifically for cardioembolic risk, for the risk of cardiovascular events in patients in the case of arterial thrombosis, and on the other hand, also based on the risk of thromboembolism, venous. The microvascular domain is separated and rigorously defined. A review and modification of the obstetric domain is also carried out, which we will look at later as well in the following slides. However, this last point has been heavily criticized because it seems that it does not adequately classify patients with APS. Obstetric APS, and as we have already seen, 2 new domains are included, cardiac valvulopathy and thrombocytopenia. Regarding laboratory criteria, for the first time, isolated positivity of the lupus anticoagulant test is included, but with the lowest possible score of a single point. They maintain the definition of persistence at 12 weeks and separate positivity into moderate, high positivity for anti-cardiolipin and anti-beta-2 glycoprotein I antibodies. I'm not sure if you can see them clearly, but the criteria, as you can clearly see, include these entry criteria, which are essential so that, if a patient has a clinical event score, along with 1 point from laboratory test results, the criteria could already be applied effectively. And as we've already reviewed, it is absolutely crucial to rule out any other potential causes that could explain the clinical manifestations. In order to associate them with APS and the assessment based on the patient's cardiovascular risk and embolic trauma, such as And now moving on to talk about the treatment of APS. For this, I've based it on the 2019 EULAR recommendations. And EULAR, first of all, gives us a series of general recommendations. The first of these is the risk stratification of patients with APS and its importance, which we'll look at next. Then, it also provides a series of general recommendations for patients who are carriers of antiphospholipid antibodies, such as screening and controlling cardiovascular risk factors, as well as assessing the risk of venous thrombosis and the use of low molecular weight heparin in high-risk situations. It also emphasizes the importance of patient education and monitoring adherence to treatments, and also monitoring the INR in patients treated with vitamin K antagonists, among other things. Regarding risk stratification, one of the most important aspects considered in the recommendations is the antibody profile. A high-risk profile is defined by the presence of a positive lupus anticoagulant test, double or triple positivity, double referring to the presence of both anti-cardiolipin and anti-beta-2 glycoprotein antibodies, and triple including all three. A positive lupus anticoagulant test is considered high risk, as is the persistent presence of high antibody titers. Other factors to consider include a history of thrombosis and obstetric complications, the coexistence of other systemic autoimmune diseases, especially lupus. Also important is the presence of other traditional cardiovascular risk factors such as smoking, hypertension, etc. There are two scales for assessing the risk of antiphospholipid syndrome. One is the antiphospholipid score. This one only takes laboratory parameters into account, which is a limitation given that these laboratory techniques are not standardized, and therefore it is difficult to apply this in clinical practice. And finally, the global antiphospholipid syndrome score. In this case, other factors are also included, such as cardiovascular risk factors in the risk assessment. And just to note that a score higher than 12 would be considered a high-risk category. It is important to note that these scoring systems are mainly used in clinical trials or studies and not so much in clinical practice. Now moving on to talk about treatment. Regarding primary thromboprophylaxis in asymptomatic carriers with a high-risk antibody profile, the use of low-dose aspirin is recommended, defined as a dose between 75 and 100 milligrams per day. In the case of patients with SLE, again, if they are at high risk, the same recommendation applies as before, low-dose aspirin. And for low risk, the use of aspirin should or could be considered in patients with a history of obstetric APS, but who are not currently pregnant, and if the goal is to provide thromboprophylaxis, primary, it is recommended to consider low-dose aspirin, as long as the risk-benefit balance is appropriate. Regarding secondary thromboprophylaxis, in patients who have experienced a venous thrombosis, the recommendation is the use of vitamin K antagonists, aiming for an INR between 2 and 3. And in this case, EULAR indicates that we could consider direct oral anticoagulants, but we will discuss this later in topic number 3. Regarding the duration of treatment, if we can identify a cause that triggered the thrombotic event, in that case, the duration of treatment would follow the recommendations in international guidelines, although in high-risk cases we might consider indefinite anticoagulation. But if we cannot identify an event that caused the thrombosis, then anticoagulation should be indefinite. In cases of recurrence, it may be considered, for example, to increase the INR target to 3 or 4, potentially switch to low molecular weight heparin, or add low-dose aspirin such as 81 millilalaron. Additionally, consider using pauses for emphasis. Regarding arterial thrombosis, again, vitamin K antagonists will be the recommended treatment. In this case, we can initially consider a more aggressive INR target between 3 and 4, depending logically on the thrombotic risk, but also taking into account the patient's risk of bleeding. In this case, EULAR tells us that the use of direct oral anticoagulants is contraindicated. And in this case, the duration should also be indefinite. In cases of recurrence, then, it may be considered to increase the INR range again to 3 or 4 if we haven't done so previously, or switch to heparin, or add low-dose aspirin. Other treatments we could consider include adding hydroxychloroquine or statins. Moving on to obstetric APS. In patients who are antibody carriers but have never had clinical manifestations, the recommendation is to consider adding low-dose aspirin during pregnancy. In patients with a history of obstetric APS, treatment will depend on the manifestations they have experienced. In cases of spontaneous miscarriages, at least 3 before the 10th week, or a fetal loss after the 10th week, the standard treatment is considered to be low-dose aspirin and prophylactic dose heparin. In cases of preterm birth prior to the 34th week or obstetric morbidity that does not meet classification criteria, the recommendation is to always use low-dose aspirin and consider adding prophylactic heparin, such as. And in refractory cases, which we will also discuss in topic number 2, the recommendation would be standard treatment, but therapeutic doses of heparin could be considered, along with the addition of hydroxychloroquine or low doses of prednisolone. As a second-line option, immunoglobulins would be considered. In cases where prophylactic heparin is used, the recommendation is to maintain it for at least 6 weeks after delivery due to the risk of thrombosis during the postpartum period. And in the case of patients with a history of thrombotic APS, in this situation, we will need to use therapeutic doses of heparin. Catastrophic APS is a rare but very serious and potentially life-threatening form of antiphospholipid syndrome, characterized by the involvement of 3 or more organs, systems, or tissues within a period of less than 1 week. It requires histological confirmation of thrombosis in the microvasculature of at least one organ. One very important thing to keep in mind in these cases is that, in the vast majority, there is a triggering factor, which can be infections, surgery, or the discontinuation of anticoagulation. And whenever possible, we should try to treat the underlying triggering cause. As first-line treatment, once again, anticoagulation with heparin will be the cornerstone of therapy, along with glucocorticoids, plasmapheresis, or immunoglobulins. And in refractory cases, we could consider adding rituximab or eculizumab, as we will see later in topic 4.